And I'd like to welcome everybody to CAPPI Chat and thank Dr. Savage and Hill for coming in to talk to us today about substance use in adolescence. So with that, I will turn it over to you both.
Sure. Thank you. Let me make sure I'm on the right screen. So neither myself nor Dr. Savage have any financial or any other sort of disclosures. And what we hope to address and cover today is really talking about the most common substances used by adolescents, and discuss how understanding adolescent development and what happens cognitively in addition to in other areas is important to actually being able to understand, manage, and treat substance use disorders in this population. Review risk factors and signs and symptoms of when substance use becomes something that is more of a substance use disorder as opposed to experimental use. Explain how parents and healthcare providers can identify substance use and describe how to manage and treat problematic substance use in this population. And so we have two different cases. Each of them are particular patients that we see. And so this first patient is one of my patients. And so AB is an 18-year-old male who's new to the clinic, presenting with concerns for anorexia and depression. He feels as though he's lost 30 pounds in the last 5 months. He does not report any throwing up, exercising, use of any medications that we know can particularly help individuals lose weight. He also recognizes that he is too thin. So he's telling you that he knows he's too thin. And so he doesn't have this kind of abnormal view of how he appears compared to how the rest of the world sees him. He also reports that his mood is sad and angry most of the time. His PHQ-9, which is a depression screener that we use in our clinic, is high. And you can see it's positive for moderate depression. And then he comes in with his grandmother, who is his legal guardian, and she's concerned because she says that he drinks a lot. And so, as I mentioned, this individual's depression screen was positive, and was out of mild, moderate, and severe, was positive in the moderate range. And then we gave this individual the craft screen, which I believe Dr. Savage will talk on shortly. And that was positive specifically in regards to alcohol. And when you ask him about his alcohol use, he does talk about drinking beer, hard liquor, wine coolers, and he drinks virtually at least one of those every single day. And then when you look at his vital signs, you note that his blood pressure is mildly elevated, but it's not in the hypertensive range. And then on exam, he looks extremely sad. We would say his affect is really flat. And then he's extremely thin to the point where he actually looks emaciated. So that's this first individual. And thinking through the fact that they came in with depression and anorexia as their actual concerns, and kind of understanding how we need to understand this individual's substance use in order to actually treat depression and or anorexia.
Right. So, and this is our second case example is one of my patients, JC. So she's a 15-year-old young lady who came into clinic for her physical, which is usually a yearly visit for most of our teens. And her mom expressed concern about her grades and possibly ADHD as a reason for her having difficulty with focus potentially. So she's never been treated for ADHD, but the family had always had a concern for it in the past. She did a substance use screening tool, and again, the one we use in our clinic is called the CRAFT screen, which is validated in Adolescents. It's CRAFFT. I actually don't have a slide on it today, but I can talk about it more if anybody wants to. So she screened positive on that for nicotine and alcohol use. And by the way, they do complete these screening tools in a room without their parents, so it's meant to be confidential. And when you ask the patient more by herself about mood issues or anxiety or different psychological concerns, as well as substance use, she tells you that she vapes daily, and she has for the last almost 2 years. And she does binge drink alcohol about once a month. And her biggest complaint is difficulty concentrating at school. And in the mornings, especially, she's quite irritable, which again can be a sign of many things, especially in adolescence. But that's sort of the main concerns we're dealing with on her visit. So, and I think I'm going to go through these next few slides, and then we'll move on to adolescent development. But today there was a focus on alcohol and nicotine as the big substances that we're going to talk about, and that's what this slide's about: the most frequently used substances by adolescents. So, alcohol is definitely number one, and the main way adolescents use alcohol is by binge drinking. So it's not typically this nightly pattern of drinking. Like, they're going to use alcohol, multiple drinks per session, and in order to get drunk or get have the those changes that make them feel more comfortable in social settings and things like that. But with that becomes a lot of risky other behaviors and decision making that might happen. But I just wanted to bring up alcohol again as the most commonly used substance by teens, and second right behind it is nicotine, and vaping specifically is the biggest way that teens use nicotine. I'll talk a little bit more about those in the next two slides, but one shout out to marijuana being very close behind vaping in its frequency of use among teenagers. So they're neck and neck in terms of with vaping and marijuana in terms of how many adolescents use over the past year when you look at the data. So, but we're going to focus on alcohol and vaping.
And I'm going to just add one thing, and don't forget, some individuals can use devices where the nicotine and the marijuana are combined. And so it's also common for especially some of the older teens to be using both, even if you're thinking they're using only one.
Yep. So there's a couple of slides coming here about this is from Monitoring the Future, is a screening tool that's given to 8th, 10th, and 12th graders in high schools around the United States. It's put out every 2 years. The most recent data show that for daily use of nicotine is what this infographic is showing. It's up to about 12% of 12th graders in the U.S. use some sort of vape device daily. So that's what the left panel there is. On the right, you see that at the same time, cigarette smoking over the past month has declined over the last 10 years. So the big takeaway here is kids, our adolescents just don't really smoke cigarettes anymore. They do sometimes, but it's not as cool. It's not the first thing that they use if they're going to try something. That's usually the first thing they try is a vape device. And keeping in mind that also most kids who use vape devices later on do become cigarette users. So just to show that we know vaping's an issue. And then the next slide is a similar is data from Monitoring the Future for drinking and alcohol. So it just shows you binge drinking rates in the past. Let's see, I thought this was past month on the left, but it must be past year. Binge drinking, and then past year alcohol use there on the right, and it splits it into 8th, 10th, and 12th grades depending on the color you're looking at. So that just shows you in the past year about 50% of high school seniors have had alcohol use. And again, I didn't talk about binge drinking. So technically, binge drinking definition is 5 or more drinks in a row. And so it would be an amount, and those are standard drinks, which most of the time people aren't just drinking standard drinks. So like a standard drink of beer, regular beer would be like 12 ounces, or wine would be like 4.5 ounces. So that's a standard drink. And it usually takes 5 of those to get your blood alcohol level to 0.08 or the legal limit. So that's where that definition comes from. And keep going.
Yeah. And so we're getting ready to switch into adolescent development. And the reason we thought it was important to have this section in this talk is both Dr. Savage and I are pediatricians, and we're also adolescent medicine physicians. And we recognize that although many adolescents look and appear to function similarly to adults, and we're even going to go through and define what adolescence is, like what that actual age range is, the reality is their brains are not functioning fully like adults. And so it's really important to kind of understand all the different nuances that go into the young person that you see before you, so that you're actually able to treat them appropriately based on how old they're behaving as opposed to how old they look. And so as I alluded to, there's actually 3 stages of adolescent or adolescent age ranges. And what's probably most interesting is that most people don't think about the later stage, which is called late adolescence or young adulthood. Usually, I think most of us think once you're 18, you're an adult. And while that's true in many situations as far as legally, the reality is your brain is still developing, and we'll talk about that in a second. And for that reason alone, you are actually still an adolescent as far as how you might behave. And that doesn't mean that you're going to behave the same way as a 13-year-old would, but it does mean that you're not behaving the same way in which a grown adult would, someone that's 26, 27, 28, 50, 80. And it's also important to understand that while we're having brain development, which I'll go into, there are also changes in the individual's body, individuals' desires to have sex, or even how they might identify as far as their own gender, and what's going on socially. And all of these things are going on in a person whose brain is still fixing the wires and figuring things out. And so it doesn't take much for maybe a friend in a peer group to have an influence, or to see an impact from something in the family, or even to witness something tragic, to actually shape and change and redirect how things are going to go as far as development in this age group. And so it's really important to understand that. So you can see this slide isn't meant to be anything extra complex, but it's this idea that there's brain development. And so they used to say that in general, during the period where most of us think of adolescence, maybe 10 to 18 or so, you have different areas of the brain that are all undergoing structural changes. However, what we've learned over the last probably decade or more is that these changes, specifically within the frontal cortex, which is the area of your brain right here, actually continue far into the mid-20s and probably finish complete development by 25 years of age. And the reason that's important is because your prefrontal cortex developing into your frontal cortex is where you kind of understand risks and benefits. It's where you get your stop button or the pause button. Let me figure this out. Let me assess what's going on. All of that is in your frontal cortex. And all of that is continuing to grow and mature. Dr. Savage uses the word often of pruning, and your brain is pruning away some of the more earlier parts of your brain, some of the parts of the brain that are associated with what we do as children and as babies and as infants. And all of that's going on during these first 20, 25 years of life to get us to who we are now. And it's really important to understand that. I can't emphasize that enough. And then in particular, Dr. Savage is going to talk about, how to recognize signs and things of any kind of substance use, let alone problematic substance use. But it's really important to understand when you see these things in our younger or early adolescent individuals, because early adolescents, so those like 10 to 13-year-olds or so, they really, really do struggle with understanding consequences of risky behavior. Yes, you can probably tell them something 1,000 times and they actually do get it. But for things that deal with their actual development. So like maybe you shouldn't hang out with your friend Sally because Sally seems to always be getting in trouble with the police. Those kind of things, it actually takes them a second to actually understand and put the pieces together, even if they're a straight A student, even if they're shaking their head and nodding at you as you say it. There's also limited ability, like I said, for cause and effect, as well as to understand long range health risks. And I know for people that might have some kind of healthcare training or an education, there was the idea that you used to tell people don't smoke because you can get lung disease, you can have heart disease. The reality is, and the best way to approach the teenage population, even maybe an 18-year-old, is, maybe you shouldn't smoke because your breath will be kicking. Like your breath will really smell. And that's the reality. And so understanding their long range health risk is very different. The ability to conceptualize that is very different than, all of us. And granted, as you get closer to that 25-year range, it gets better. But humor me. Think about what's going on right now with COVID-19, right? A lot of our 20-somethings are like, well, I'm okay because I'm not likely to get COVID-19. Or if I get COVID-19, I'm not going to have these long-term side effects you guys are talking about. That's a prime example of the fact that many of those individuals are still going through adolescence. And once you understand that, then you start to understand why they're behaving in such a way, and you can actually change behavior. And then the last thing is that most adolescents have this concept of immortality, this concept of, again, like, nothing's going to happen to me, or if something does happen, I can overcome it. And so when you talk about substance use disorder and young people that are using something, and maybe they drunk once and they got behind the wheel of a car and nothing happened, that actually speaks volumes to them, because they as part of their very nature, like, okay, I know I'm likely to live to be whatever age. I know I'm likely to be healthy, and so on and so forth. And so having these experiences where there is a degree of risk involved, and the adolescent is actually able to survive and overcome without negative consequences, actually reinforces their concept of immortality. I think this is you, Dr. Savage.
Yeah. I wanted to make sure you didn't want to talk about it. Yeah. So I've shared this slide here with you guys, and so piggybacking right off the adolescent development and brain development is that because the brain is still under development, undergoing so many changes, we know that the earlier one uses alcohol or marijuana for the first time, that the higher their risk of having a substance use disorder. So just this one paper here, and this graphic that comes from it, the table here, is that it shows that for those who used alcohol for the first time at age 13 or younger, they were 47% of those young people ended up having an alcohol use disorder. Whereas if the person were to wait until 21 years of age or older, of that population, only 9% of those had a substance use disorder. So the age of drinking onset is very important. And this applies as well to cannabis and nicotine, in that those who use earlier at an earlier age are much more likely to develop problematic substance use later, or a substance use disorder. And again, that has everything to do with brain development. And then the reward center is very different in an adolescent versus an adult. And just they're sort of primed to develop addiction at a much higher rate than if an adult used a substance for the first time. And that, you can keep going, Sam. Yeah, and so we're going to talk about a little bit about how to identify patients in terms of thinking through what are risk factors and also protective factors for drug and alcohol use. So, just putting it in a table form here, and we like to think of risk factors as well as protective factors, because there are a lot of positive, good things about the young people that we work with, or our own children, or because we like to think of the pros and the cons, you know what I mean? Like the positive side of things. So a lot of times we'll start though with risk factors. So I'm going to start talking about what some risk factors are at the individual level, at the personal level. So I just talked about how, earlier age at first use of whatever substance is going to increase that person's risk of having problematic substance use or ongoing substance use. And then if a young person has a mental health problem already, especially ADHD, conduct disorder, some other sort of, disruptive behavior kind of issues, that tends to be a risk factor for having substance use as well. And then, of course, just their genetics, any history of trauma, which Dr. Hill will talk about in a moment. And then just their attitudes and beliefs, that person's attitudes and beliefs around drugs and alcohol, which is where parents come in to be very important here, as we'll talk about in a little bit. So individual protective factors include things like that, like perceiving drugs as high risk and something I should not be doing, having more self-control or autonomy, or just, self-efficacy or confidence in one's ability to make good decisions, and a lot of that is based around sort of parental support as the child is growing up, of course. So, and then school-based extracurricular activities typically are a protective factor for substance use. And I think a lot of that is just structure and monitoring and, keeping somebody busy, honestly. That's kind of what we see a lot in our clinic, is just, those who just don't have a lot going on. And for lack of a better word, they're bored and they sort of just get into trouble more, honestly. So then family-wise, if a parent uses substance use or family members do, that's obviously a big issue, both environmentally, but also genetically. That's putting a lot of, increasing their risk a lot for having their own substance use problems. And then if your parenting style is warm, or if you have clear parental expectations about drug use, then that's going to be a protective factor against having drug and alcohol problems. So, and at the school level, if there's peers that they're hanging out with that also use drugs, obviously that's going to increase one's risk versus peers who don't use drugs. And then going on to, all the socioecological levels here in the community. So the community is also an important factor in terms of what is crime like in your community? What is the safety in your environment? How is law enforcement? And that's specifically too, I think of one patient I have right now whose mom keeps coming back to me saying, this gas station right in front of this girl's school is the one selling her these vape pens. They know she's underage, and the mom has called law enforcement on the gas station multiple times. But it's things like that. Like, is there law enforcement around making sure that teens are not even able to purchase some of these drugs and alcohol? And what is that like in that community? So that's just one broad, and there's many more that we could talk about, but that's just one broad look. And then thinking about individuals, like when a patient comes into clinic with me or Dr. Hill, and the parents are bringing up some concerns. This is more often than not what happens. And like with my patient I talked about earlier, well, their grades are suffering, and we think that she's just not able to focus first thing in the morning. She has a really tough time at school. But when you start hearing about school problems, or actually she quit the soccer team, like she's always loved soccer, but this year just didn't work out, and we're like, okay, wait, so she quit the soccer team. She's doing worse in school. Like, she's always irritable. Oh, wait, she's got some new friends. I mean, these are all red flags, right? That something else is going on, which it doesn't have to be drugs and alcohol, but it could be multiple things. But drugs and alcohol are one of the big ones we worry about. And then, of course, isolation, having more risky behaviors, complaining of sleep problems, somatic complaints. So all of these, like I said, they could be mood, anxiety related, multiple things, but drugs and alcohol are really important for us to ask about specifically.
And so, when Dr. Savage was presenting a social ecological model, which is the overall large framework of how to look at one individual and their risks and protective factors regarding substance use, she had mentioned the word trauma. And before we even get into the idea of trauma, it's important that we understand something called ACEs, which originally stood for adverse childhood experiences. And so ACEs was a term that came about early in the 2000s from this very large study done by Kaiser over on the West Coast, where they took adult individuals and gave them this extensive survey to complete, asking them a lot of personal history questions about what happened to them when they were young people and children. And what they were able to find was that this original column of items that are listed in the left in this dark forest green color were these original ACEs, or these original adverse childhood experiences that, depending on the number that individuals had, they actually had increased risk for a host of things. And I'm going to show you in a second how substance use is one of those host of things. But as you can see, the original adverse childhood experiences include a lot of mental health concerns, including types of abuse, including sexual, physical, and emotional abuse or neglect. You also can see divorce, and then you could also even see an incarcerated relative. What we've learned in the last 10 years or so is that this is not an overall summation of the different types of events or experiences that a young child has that can impact their actual health outcomes as they get older. And so these other three scenarios or conditions were created. So adverse circuitry expression, and you'll notice this group is actually a lot of different medical conditions, some of which are genetic, some of which you're born to, maybe born with because of what happens in utero or when you're in mom developing. And then you see adverse community environments and adverse cultural exposures. And so we know things like social determinants of health definitely impact any single individual, whether they're a baby, a child, a teen, or an adult. And so how your access to food, your access to having a safe place to lay your head down at night, your exposure to certain types of housing, your access to medical or other kinds of conditions, safe schools. That's where that comes in. And then adverse cultural exposures has been something that people have long advocated with, right? The idea that, you know, continual experiences of discrimination of any type over long periods of time actually start to impact something within you and increase risks of either you engaging in a behavior, such as maybe a substance use behavior, or having a negative health outcome, such as depression, like that's uncontrolled, undiagnosed, or even heart disease and things like that. And so this is one of the actual figures from one of the original studies on ACEs. And you can see, and I circled substance use since that's what this particular talk is on, but you can actually see that the study, which found that more than 60% of individuals that they surveyed actually had at least experienced one, if not more ACEs. So there were very few people that had reported no ACEs, experiencing any ACEs. But you can see as the number of ACEs you experience, and these are the original ACEs, these are not even inclusive of the other 3 categories that were added on later. But as you actually experience more ACEs, your risk for different conditions actually increases, and that actually does include substance use. And you can see the other ones there, and it's actually in a linear form. And so this is something that's really important for us to identify, whether this is with our own kids, whether we're in school, whether we're in the healthcare system, is kind of being able to recognize these ACEs. And depending on an individual's life experiences and the repetitive or lack thereof nature of them being exposed to these things, they might actually even be experiencing trauma. And trauma is this broader definition that is traumatic event that's frightening, dangerous, or violent that poses a threat to a child's life or bodily integrity. Now, for many of us, that might mean, okay, they were in a car accident or they've been shot at, but there's actually a variety of different things that can constitute trauma. Because this is really about how the individual is reacting to the actual experience. And so it's really important to understand that this should not be a limiting definition. This should be an expansive definition to give you an idea of trauma. And it's important that we, in whatever capacity we interact with young people specifically, are able to recognize trauma and work to address it. And so the prevalence of trauma, so you can see that adolescents, about 46% of them have had at least one traumatic event. That's almost half of the young people. And this study was actually done in this country. Half of the young people here. So they didn't break it down by race or ethnicity. It didn't break it down by gender. It didn't break it down by SES. Half of the young people have had at least one exposure to something that classifies or qualifies as trauma. And then 25% of those individuals actually develop symptoms that someone can recognize as trauma. So you might be thinking like PTSD or something like that. That is a type of symptom or experience you can have from trauma, but that's not the only type. You could have changes in your sleep behavior and things like that, which we'll get into the next slide. But you can actually see the prevalence of trauma broken down here by age in the center graph. And again, the key takeaway is, you know, again, 46% of all children, the youngest children at 35%, but then as you live, right? We say as you live, you experience more life. And so as you live, you can see our young people, more and more of them are being exposed to trauma. And so thinking through this, and that's just one. And you can see almost a third of our young people by the time they reach 17 have had an exposure to at least 2. And so when we talk about trauma, according to the American Academy of Pediatrics, they have this nice little mnemonic you can use to kind of help you remember what things you're seeing might be a sign of trauma. And so they call it FRAID. And so it's this idea of fits, frets, and fear. So they're really anxious, they're sad, they're screaming, they're having tantrums, they're always afraid. That's the F. Regulation disorders. So that might be regulation in mood. So they're going from really happy to really sad to really irritable to really angry. Or it could be sleep regulation, attachment disorders. So this could be something like, you know, you have a young teen or whatnot that comes into clinic and you are their new best friend in an unhealthy relationship. They are like, okay, I've made this connection with this doctor. They have no sense of the fact that you have boundaries. And so they're trying to contact you and expect for you to respond at all times of the day or the night. There's yelling and yawning, which goes back to that fits, frets, and fear. So again, the emotional dysregulation and the sleep disorders. educational delays. So I know Dr. Savage's patients she mentioned, the two patients she mentioned actually have different challenges as far as their academic work. And so this could be something like you have a great student and now they're struggling. This could also be students who have gone unrecognized for years in the ability for them to complete their work, and people like, oh, they just are slow, or oh, they're not behaving appropriately, or these horrible things that we say about our kids. Those actually might be signs that this kid is living and going home every day to a house or an environment that's filled with trauma. And then defeated, so the hopelessness, right, which we recognize very clearly when we talk about depression, but that hopelessness is seen here as well with trauma. So I bring this up because in order for us to do what Dr. Savage is getting ready to talk to us about as far as identifying individuals that might have substance use disorders and managing individuals and working with individuals that might have substance use disorders, it's really important to understand that you need to use a trauma-informed care approach in order to actually work with these individuals. And it's important that I say that because a trauma-informed care approach is not a paternalistic approach that, depending on what you do for a living or what your training is in, you probably were taught. I can speak as a physician. A lot of times in the past, we've been taught very paternalistic ways of treating patients. I tell you what to do, you do it. This is not what trauma-informed care is about. This is not what helping these individuals is about. And so you can see trauma-informed care is a system in which all parties, so the person you're working with, the teen, as well as yourself and whoever else is involved, they're recognizing and responding to the impact of traumatic stress on those who have contact with the system. In this case, because Dr. Savage and I are both physicians, the healthcare system. And then we infuse and sustain trauma awareness, knowledge, and skills into our organizational culture, practices, and policies. And we act in collaboration with all the parties that are interacting with this particular individual, trying to maximize the safety, facilitate the recovery, and support the child's ability to thrive. So that very long, wordy definition that you were probably like, we could have read that off the screen. It's important that I say all those things because trauma-informed care is not something simple. It's not just, I recognize there's trauma, it's how you also respond. So the 4 R's of actually working towards being someone that is that is a trauma-informed provider and is able to actually work in these kind of systems is, one, you realize that trauma is actually almost a universal experience. Most of us have experienced trauma. Even most of us on this call, we might not recognize it, but if you were to sit down, you might be able to recall some trauma you've experienced. So recognize that there's widespread experiences and impacts from trauma. Then you want to recognize the signs and symptoms that Dr. Savage has already talked about for individuals that have experienced trauma. You should be able to start to recognize those. So that looks like for us in healthcare world, when a patient or a parent even comes in and they're extremely angry and you're like, the visit just started, I don't understand. That's not me, I didn't do anything. That's also not the parent or the patient being a bad person. That's a sign that there's some kind of trauma in their life that is impacting how they're interacting with the world. And so a non-trauma informed care approach would be to ask for me to go in and be like, hey, you need to be quiet, get your act together, or something like that, or getting maybe your nurse to go in and be like, hey, if you don't calm down, we have to ask you to leave. That's not trauma informed care. That's the farthest from it. And so you have to kind of learn how to assess your reactions when you get those individuals that you work with, whether it's in schools or the hospital or out in the community, and they say something and it's like, it's pressing all your buttons and you're not sure why. That should be a sign to you to be like, oh, wait, maybe there's something else going on with this person. And I need to put my trauma lens on. That's what that's about. And then respond again by making sure that the people that you work with, the communities, the environments you work with have this same kind of perception of, I need to understand what trauma is, I need to be able to recognize trauma, and I need to make sure that my policies, my procedures, the systems that I work in are actually set up to be safe places so that people that are experiencing trauma don't come in and get re-traumatized, which is the last particular step. So when we have these visceral reactions to someone who is in a bad mood or is yelling and shouting and we yell and shout right back, all we're doing is re-traumatizing them. We're showing them that our particular system in which we work in is actually not a safe place, that it is not a helpful place, that we do not see the best thing. And it's super important to understand this because a lot of times you will have some of these teens that have substance use disorders or even maybe some casual substance use come in, and they not only have experienced trauma, but they also might be particularly under the influence of that particular substance. And because of that, the way in which they interact with you, your healthcare team, your school team, whomever you work with might be different than what you wanted, what you anticipated, what you expected. And if you don't approach them with a trauma-informed lens, you're actually just adding to the problems that they have.
Yeah, thanks, Dr. Hill. That was really good. Yeah. So I'm going to talk a little bit about how to identify substance use, what a substance use disorder is, and then sort of what it would mean to appropriately address the substance use problem and then manage it and treat it. So next slide we'll talk about, and a lot of you probably know this. I'm trying to think about the audience. I'm looking through names over here on the Zoom screen, but I think, you know, most names I know of are at least in sort of a public health, healthcare, psychology field. Can anybody else give a shout out to a different field, or if you're just like, I don't know, even just a community member or a parent, I don't know, or put it in the chat box. Sociology, thank you. Okay, so yeah, anybody else who has another field that I didn't include? I'm trying to make sure I address you guys appropriately. So for knowing what a substance use disorder is, again, this definition comes straight from the DSM-5, the catalog for psychological disorders, and I've split the 11 criteria for substance use disorder into 4 broad areas. And so you'll see A there, it says impaired control. So at some point, if your substance use has turned into where you're using larger amounts of the drug or over a longer period of time, you've tried to cut down and you haven't been able to, you spend a whole lot of time thinking about obtaining it, getting it, using it, you have craving for it. So those are all criteria for impaired control of use. So that's one big category under substance use disorder. Another is having social impairment because of your substance use. So it's difficult for like a young person to manage their grades. So that's why we keep bringing up school, as grades falling is a sign of a drug problem, right? Because you're not able to manage that commitment to your schooling. If you're having personal problems, either with friends, with family, you have reduced activities, meaning you're like not playing on that soccer team anymore because you just were too busy, you know, using drugs, or you got into trouble and they kicked you off the soccer team or something like that. So that would like meet the criteria for having some kind of social impairment because of drug use. And then there at C, it says risky use. So this is criteria 8 and 9. So using alcohol, drugs, whatever drug it is, even when it puts you in danger or in dangerous situations, in situations where it's going to make a physical or psychological disorder you already have worse. So an easy example of this is someone who's vaping, who already has severe asthma. And so just an example of that, like they know it makes their asthma worse. Yes, they cough more, but they still vape. So check, you know, they have that criteria. And then having criteria 10 and 11 there, we just call pharmacological criteria, meaning you've used a substance enough to where you've developed tolerance to it. So you need a higher amount of the substance to have the same psychological effect or even somatic effect. So, and then you have withdrawal and you don't use. So withdrawal symptoms from not using. So I know a lot of y'all probably are aware of this criteria, but I use this. I know our psychology team in substance use assessment clinic here at Adolescent Health Center at Children's, we use this criteria to, as we speak with each other and as we speak with patients and families, to identify who has a substance use disorder and for what substance, and whether it's mild, moderate, or severe, as you see there in the red. So you only need 2 of the 11 to have a substance use disorder that's mild. And again, you change the terminology to, if it's specifically alcohol that this person struggles with, you call it alcohol use disorder versus nicotine use disorder, cannabis use disorder. Okay. So we use this all the time. You can go to the next slide.
And while I'm clicking, shout out to Catherine Thompson, who's actually on here, who's part of our team.
Yeah, I saw her pop in.
Thanks, guys. This is a great talk.
You're so sweet. That's funny. And I saw Dr. Austin on here too a minute ago. I think she had to leave, but I might be wrong. But Heather Austin is our faculty psychologist over here. So, okay, so I was thinking about this talk, and again, the topics focus on alcohol and nicotine. Again, I wasn't sure. I know that our audience is quite broad, but I wanted to bring up just a few thoughts for both providers and parents. And I want to leave, it open as well to questions after this for depending on your place in your work or your home life, whatever you have questions about. If let us know, and so we can try to apply some things to you too. But for providers of healthcare, we just need to make sure, and this is kind of my soapbox a little bit for pediatricians and providers in the community, to ask about it and to ask about drug and alcohol use of all adolescents, starting as early as 11 years old or even younger. It recommended to start at 9 years old for alcohol use specifically, but the NIAAA recommends that. But the providers need to be asking the question. And I say this because a lot of times in a busy healthcare setting, it's easy to skip over the drug and alcohol questions for those long visits sometimes that we have for physicals and for different issues. So we need to ask the question. We need to do so in a manner that's confidential. So that means we ask the child by themselves with the parent not in the room, which is another level of a time crunch, to be honest. But that's the only way to ask these questions, is to ask in a confidential way and in a way where the child doesn't think that we're going to tell their parent immediately what they said, So I mentioned on here, we're trying to maintain trust and a rapport with the patient, but we also want to be safe. So if there's risky use, certainly if there's like IV drug use or overdoses or drinking and driving or things like that, you have to breach confidentiality to some degree to involve the parent in that case. And again, I'm talking still in kind of a provider, like healthcare type setting. And I do that carefully with a discussion with the patient about, like, I have to share this thing with your parent, and because of this reason, this is why I'm concerned about you. Is there something about how I'm going to say this that you want me to make sure I do not say? Like, or is there a part of this that's very important I keep confidential? Because a lot of times it's just a tiny detail about how so-and-so friend was the one that gave her the drugs, so don't tell on my friend. So anyway, so you can usually work around the adolescent concerns there. But I just wanted to at least say that. So moving on to parents, because again, I didn't know if we'd have any parents on this talk, but in general, I'll go through these quickly because I don't know if we have a lot of community members or parents, but I know that there's probably parents in this group. I'm a parent, so but anyway, thank goodness I'm not a parent of adolescents yet.
I was gonna say your kids are all small,
put it off. Yeah, I know, right? Come back and talk to me after my kids are adolescents, and then we'll see kind of like how this has changed. But for parents, stay suspicious. I heard this from Stephen Taylor, who's a psychiatrist in the area that works with substance use a lot. He does a lot of talks around. But that was one thing that stuck with me about a talk he gave once, is like just harping on the parents to always be nosy, like always be sneaky, like, kind of check your child's things. Look at their cell phone. Yeah, just because they have a cell phone, you pay for it typically. So that is your cell phone. Like, you have free reign to double check their cell phone and just stay suspicious. And if there is a gut feeling that something is going on, trust your gut. And, I say this to parents all the time, that they know a lot of times they have a feeling when something's going on that's not quite lining up, that there's some issues. Ask the questions and be sneaky and help try to figure it out. Ask questions of your teen and listen to them. So being as open as you can, as warm as you can, but also making clear expectations and boundaries. So that jumps to never treat alcohol and drugs as a, quote, normal rite of passage. So this comes up a good bit in clinic as well, or just in the community and talking with parents, is that it's important to know that it's not normal for your teens, especially high schoolers, to smoke weed. It's not because it's not, the majority of kids do not smoke marijuana. The majority of kids still don't vape. Um, so, the majority of kids still don't binge drink. So it's not normal to expect it. So I think if parents can shift and make a clear expectation that of their child, that we expect you and expect of you not to smoke, not to vape, not to use marijuana, not to drink alcohol, and don't think of it like, well, they're going to go party on their own anyway, and I would rather them party in my house where I can provide the alcohol and I can be monitoring what's going on. That gives the wrong impression, and it's never been clear that actually helps with reducing substance use or alcohol or drug problems in teens. If anything, it gives them a permission to think that this is appropriate behavior. So that's a difficult conversation to have with parents sometimes, though. I speak about it bluntly with you guys, but sometimes it's a discussion that's tough to have with the parent, because it might mean them changing some things that they've done. But I think that's an important thing to communicate. And then I always mention about parents administering all medications and locking up all medications in the home. And that's thinking more about prescription drug issues or misuse. But that tends to come up a good bit as well with our substance use patients, like finding, whether it be pain pills, ADHD meds, whatever it is in the home that aren't locked up, or using their mood medications the incorrect way.
Yeah. And I like Dr. Savage, what she said very quickly about checking the phones. I don't know if people saw the news. I think last week, a very prominent news consultant for one of the major networks, her son basically overdosed. Great student, had all these plans to go to college and do X, Y, and Z, was applying to colleges at the time, and was just like many young people, bored. It's COVID. They're doing the social distancing, they're at home. And so got on his phone, which his parents didn't have access to and are still trying to get access to a week after his death. Went to wherever he went to, and they had this list of cutesy things for him to try. And no, it wasn't alcohol or tobacco, but he picked up one, and he thought he was getting, I think, I don't even know, maybe like an ADHD pill, but it was like a pure fentanyl pill with a little bit of something else laced around it. And he was like, his mom hadn't heard from him in like an hour or whatever, checked on him, and he was already gone. And so I say that because he was a good student. He had goals. He had all these other things that he didn't quite fit our normal signs and symptoms. But what Dr. Savage said about checking your phone, checking your kids' phones, or having passwords and things, is really important and not to take lightly, as well as the locking up of medicine. Sometimes our overachieving students, they've got their medicine, they're actually selling it, which is actually a felony as well. And so there are a lot of tricks and trades to this that go beyond just always thinking about this person seems to be struggling in all areas of their life. Sometimes these kids are doing great so academically, but maybe not in other areas.
Yeah, that's a good point. So what to do next? I know that we're kind of toward the end here. You go to the next slide, Sam. So, and again, this might be a good place to ask for some thoughts from you guys or questions, but just depending on where you are, some of my big things I wanted to mention was, if it was a parent or some concerned person that in your life that you're concerned about, you can always ask if there is a substance use problem, like you've seen all these signs we've talked about, you're worried about some of those substance use disorder criteria. What do you do? So, and I'll give y'all some resources locally as well that a lot of you probably know of, but one thing is just to ask your doctor about a referral. So again, we exist here at Children's within the Adolescent Health Center. We have multiple MD providers here who see patients, but I try to have this clinic specifically with psychology present to be able to assess young people for substance use disorders. And the reason why psychology is also so helpful, one of the many reasons that they're vital, I think, is that they're able to help not just with diagnosing those substance use disorders, but also what other psychological disorders are going on Is there probably an anxiety disorder as well? You know, did that predate what's been happening with the substances and how to figure that out? Is there a mood disorder going on as well? You know, and we just sort of go through over multiple visits. As y'all can imagine, it takes 3 visits usually to really get all of this piece together. But come up with, you know, what disorders are going on and what level of treatment do we recommend? And that goes to that third bullet here, where it's treatment for substance use can occur at multiple levels. And this is a lot of text, but all it's saying is like, this is what I'm thinking about at the end of the day in clinic. Like, after we have these diagnoses going on, how do we most help this patient? And a lot of times it's sending them or giving them options for a residential program. There are not many. There are very few actually, and there's only one I know of in the state. Well, that takes, I should say there's more than one, but there's one main one for private insurance. But there's some options in our state, but there aren't many. And then there are some in surrounding states for residential. Or is it something where the patient needs just extra counseling 3 to 4 days a week in an intensive outpatient program? And otherwise, most of our patients remain at an outpatient level, which is where the maximum they can see any provider is about once a week. And again, we always say to optimize the therapy piece, the counseling piece of that. So a lot of these patients may already have therapists, and in that case, we ask the therapist to make sure they're incorporating substance use into their therapeutic approach, or we're telling the parent to request a meeting with the therapist to talk about things. So anyway, we try to piece all these things together. And Sam, you can go to the next slide. So we can, talk about our patients.
Okay. Well, so I'll remind you briefly of AB, who was the 18-year-old young man whose initial complaints coming into clinic were anorexia, in the sense of, does he have anorexia and depression? And he disclosed, and his grandmother was concerned about his use of alcohol. And this case is actually ongoing, but the nuances within this case are exactly all the different things that Dr. Savage and I hit on. So getting this extensive history. So his grandmother is his legal guardian. His mother is someone who has her own severe substance use disorder, and lost custody of him a long time ago. And actually recently gave birth a few years ago to another child, of which the grandmother just learned existed months ago after the child was removed from the home. And so not only is this young person someone that has grown up without both of his parents, we still aren't quite sure what happened to his dad. He hasn't opened up about that, but he just learned that he has a sister, a half sister, within the last year. The person he was closest to was his grandfather, who also struggled with having severe alcohol use disorder. And part of the reason he drinks in the manner in which he drinks is because that is what they used to do with each other before he passed away, when the young person was about 15 years of age. And so if you can imagine someone that's already 15 and they've gotten this bond with grandfather, and the bond involves being around alcohol, like Dr. Savage already mentioned, like this idea that it's kind of norm if I'm with you as the parent or guardian. Just imagine how hard it is for us to kind of start talking to him and helping him realize that he actually has a substance use problem. And I'll end with this. He actually, I actually went through this with my residents this morning, his particular case, using the criteria Dr. Savage showed you. And he actually has severe substance use disorder. He is positive on 10 of the 11 items, and technically I could get him on all 11 items. The learning from him is that, you know, his anorexia is not really anorexia. It's just that his entire nutritional intake comes from alcohol. He really eats maybe a sandwich, maybe a day. And when I'm talking about a sandwich, I'm talking about peanut butter and bread. He drinks very little water. I mean, he's just not functioning well. He did not finish high school. He has no plans for anything to do, and he's kind of actually in a sunken place. And the saving grace is that his grandmother is aware of his use, and so I didn't have to have that conversation with her, but his grandmother is afraid of him. His grandmother is significantly older, and is afraid of him because she does rely on him. And so there's this power struggle with me talking to grandmother because this young man is not interested in doing anything that Dr. Savage has mentioned as far as like willingly going to a facility or a treatment facility. And grandmother is too scared about repercussions to her if she were to admit him. So that's kind of his story. But the entire time we work with him, it's always a trauma-informed lens because there's a lot of stuff going on with him.
Yeah, and then my patient JC, who's the 15-year-old with daily vaping, came in for concern for focus, irritability, issues at school. We just had a discussion again. She was a substance use assessment, and we just had a discussion with her and her mom about how important it was to we were not able to diagnose ADHD at this point because he was using nicotine so frequently. So it was difficult because I wondered if she's actually having nicotine withdrawals as a part of her irritability. And then also there's this nicotine intoxication syndrome that a lot of people who use these big hits and high doses of nicotine we're also seeing in young people. So there's a lot of discussion around that. So we just had ongoing sort of motivational interviewing to try to help with decreasing use. There was also some cannabis use involved, which I left out. But anyway, so it's complicated, but it's like working with families and keeping them engaged, I think, is the piece that's the important part, just the ongoing follow-ups and the helping walk them through this process. So I know it's time and Sam and I both have clinic patients, but these are resources that I would recommend if you are a parent, if you're a person who just wants some information, and general information is easy to read, easy to share with your teen. NIDA for teens, Partnership to End Addiction, Truth Initiative, and My Life, My Quit are both nicotine focused. And then locally, Addiction Prevention Coalition is a great group that works in the Birmingham area schools. And recently I had an 18-year-old patient who we connected with this recovery center called Ross over in Avondale. I'm sure there are many more. I just had heard about this recently, so it was at the top of my mind. And then the next slide is just more resources if there's problematic substance use and a young person who might need treatment. I've mentioned us at Adolescent Help Center. We have our number and our emails at the end of this. I'm sure we could share it if anybody needs it, but multiple other places I mentioned here. I'm not going to go through all of them. And that's us. That's our number if anybody needs us in our emails. Thank you, guys.
Thank
I'm
you.
sorry we didn't have time to talk. It's 101.
Well, thank you both.
Thank you.
Sorry
we didn't have time for questions. That always happens, Sam. I always
It's okay. I mean, if someone has a really like pressing question,
if they would
Dr.
chat
Savage and I are happy to answer it really quickly. But we also know that you guys probably also have responsibilities as well.
Actually, can I ask you a question?
Sure.
So I mean, I'm always fascinated looking at things sort of from a cultural perspective. So when you look at, age of first alcohol use and relation to substance use disorder or alcohol use disorder, how does that compare to European countries where, that sort of thing is more normalized and their rates are a lot lower, but kids are exposed,
earlier
as sort of routine?
No, you're raising a good question, a good point. And I've heard this question 2 or 3 times before, and it's an interesting point because that was a US study. So I don't know the answer. I don't know if they've done the same in Europe just to see if there's a difference there. I
also wonder if it has to do with, the family's association with alcohol, for instance. So, if we were to separate it out and get families in general that were introducing their kids to alcohol, as a rite of passage, as a norm, with dinners or whatnot, if there's going to be a difference when you have families who there already is kind of a use disorder with alcohol, versus families who are like, no, we're truly getting our glass of wine with our little Mediterranean salad and fish. And, you know, maybe we have another glass later in the week or something like that. So I kind of wonder about that. And I don't know if any studies have actually compared the two, as well as looking at how the family relates to alcohol and what alcohol means for their family.
Yeah.
Rob,
yeah.
I've got to, you know, challenge you on this a little bit, because fantastic presentation, by the way, Dr. Savage. Anyway, Rob, I have to push back on this a little bit, because all the literature that I've seen would suggest that where there is greater alcohol control policy, the rates of alcohol use disorders decline.
Yeah.
And the idea that Europe has fewer problems than the US is just a myth. There's no data that support that. And there are even bits of data suggesting that when alcohol is, let's say, controlled in the family of origin, that the rates of alcohol use disorders are also lower.
Yeah.
So this idea that we should be exposing our children to alcohol so as to protect them from the ill effects of alcohol is misguided. And if you go to, say, Utah, or look at the rates of alcohol dependence among, say, the members of the Church of Latter-day Saints, where the faith explicitly prohibits use of alcohol, you find very, very low rates of alcohol use disorder. So that's my little contribution.
Yeah,
I
I would.
I don't know the stats. I mean, I just, you know, from looking at like some of the stuff from the WHO, it looks like, especially for young women, the rates are higher in North America than they are in most of sort of Western Europe.
Yeah. Yeah, it's an interesting question, because I know culturally there's differences there with how they use alcohol and treat it. So, but yeah, I appreciate Dr. Hendricks saying that, because it's funny. Like, I took his public health class, 3 years ago now it's been, and I think I read a lot. I read a lot of the papers he's talking about. So, but I appreciate you guys. And it's a good question. Okay, I'm gonna have to run. Thank you.
Thank
Yes,
you,
thanks again.
everybody.
All right, bye bye.